So hi, everyone. We'll be starting the session titled Advances in Immunotherapy Now. My name is Sharon. I'm a health researcher at the University of Minnesota in the Cancer Survivorship Program. Most of my work is with Dr. Kareem Sadak and Dr. Lucy Turcotte, and I will be monitoring the session today. During the presentation, if anyone has any questions or comments, please submit to the Q&A at the bottom of the screen or in the chat box. And I will kind of collect those questions and ask them when Dr. Kulkarni is finished with this presentation. So to introduce Dr. Amit Kulkarni, he is the Assistant Professor of Medicine at the University of Minnesota. He's a medical oncologist specializing in lung cancer, and his research is focused on developing novel biomarkers of immunotherapy. He joined the faculty in 2020 after completing his fellowship at the University of Minnesota. And prior to that, he received his MD from India and completed his internal medicine residency at Baltimore. So welcome, Dr. Kulkarni. I'll let you take it away.
Thank you. Thank you for the introduction. Let me share my screen here. Okay, excellent. Thanks, everyone. Thanks for joining. My name is Amit, one of the oncologists here at the university at the Masonic Cancer Center, and I specifically see patients of lung cancer. So I thought this was a good opportunity to talk about immune checkpoint blocker or inhibitor immunotherapy and what to expect when someone is about to start this treatment. Here are my disclosures. So when someone says immunotherapy, it can mean a lot of things in oncology. And the ones that you might be aware are immunotherapy vaccines, or they could be small molecules, cytokines, or even cell therapies like CAR T cells, or other monoclonal antibodies, like immune checkpoint inhibitors. And our focus of the talk today is going to be immune checkpoint inhibitors. When I say immunotherapy, it's basically these drugs for the purpose of this talk. It could be one of the 3 different types of immune checkpoint immunotherapy that has been approved. And we'll go over that in a second. So what are these immune checkpoints? Now, the immune system is constantly scouring our body to find out if there are new bacteria, new viruses, or even cancer cells, which can arise from our normal cells in the body. So they're constantly active, looking for these foreign substances, including our cancer cells. So, and these immune cells, especially the T cell, which is a part of the white blood cells, are the key in fighting against infections and identifying new cancer cells. So there is constant interaction between, on the right side in this cartoon here is the T cell, which is your bona fide immune cell. And on the left, it is usually typically a tumor cell. So when the T cells first sees a tumor, it obviously senses there is something abnormal and that this is probably not a part of our body. So, and when this interaction occurs, the immune cell has to either, identify and kill the tumor cell directly, or sometimes it does not. And that depends on, several signals between that are exchanged between the tumor cells and the T cells. So a part of these signals are your immune checkpoints. They're basically like your, in the immigration, right? So you have to show your passport to enter the country. So something similar to that. And these signals can either inhibit the T cell or activate the T cell. Now, the immune checkpoints that I'm going to talk about today are a part of your inhibitory signaling. Therefore, if the tumor cells and the T cell interact and the signal is to inhibit, the T cell will not recognize the tumor cell, and the tumor cell will continue to proliferate in the body. And this is a cartoon again showing a the same concept here, the interaction between the T cell and the cancer cell. And immune checkpoint blockers are nothing but antibodies against these immune checkpoints. If it is a antibody against PD-L1, it is a PD-L1 antibody. If it's a PD-1, so on either end of the interaction, if you design an antibody, that becomes your immune checkpoint blocker. And similarly, CTLA-4. So if these antibodies inhibit this interaction, therefore they inhibit the inhibition. And what this means is, in simple ways, it activates our own immune system to recognize and kill cancer cells. Since their first introduction, they were first introduced back in 2011 through 2020. So in about 10 years or 11 years, there have been more than 20 different indications for immune checkpoint blocker. And this figure basically summarizes all of that. You can see starting from 2011 on the left side, melanoma was the first cancer that had approved ipilimumab, which is a CTLA-4 inhibitor. And since then, nearly every quarter, you had one or the other immunotherapy that has been approved, especially since 2014. And thus far, there have been more than 20 different cancers in which immunotherapy or immune checkpoint blockers are approved. They can be either used by themselves, meaning like PD-L1 inhibitors, it could be pembrolizumab, nivolumab, or cemiplimab used themselves, or sometimes used in combination depending on what disease you're looking at. For instance, for melanoma, for lung cancer, or for mesothelioma, you can use a combination of nivolumab and ipilimumab. Whereas in other diseases, they can be either used alone or sometimes in combination with chemotherapies. This is a graph that I wanted to show. This is a very simple, what we call a survival graph. This is in a way a poster child of immunotherapy benefit. This is in lung cancer patients. And in this graph on the left side, on the vertical axis is survival, so 0 to 100. And on the horizontal axis is time in months. So you can see it goes from 0 to 72 months. So that's about 6 years of follow-up. And in this study, patients received either pembrolizumab, which is the blue line, or chemotherapy. And you can see that in this study, patients who received pembrolizumab had a significantly improved survival. So the blue line is on top of the red line, suggesting that you had more patients surviving who received pembrolizumab. So about 40% decreased risk of survival. Now, it's important to remember that immunotherapy is obviously different from your traditional cytotoxic chemotherapies. And also the patterns of response to the immunotherapy is a little bit different than your chemotherapy. For instance, just to give you an example, there is, because it uses our own immune system to recognize and kill cancer cells, the immune cells are recruited to the tumor. And what can sometimes happen is this phenomenon called pseudo-progression, meaning that initially there could be a slight increase in size of the tumor on the CT scan before it starts regressing. And that is because the immune system is recruited to the tumor, and in that process, sometimes the tumor can appear bigger on the CT scan. So you have to be really careful of someone who got their first scan and saying, hey, tumor is slightly bigger. Unfortunately, it might not be working. But sometimes the benefits, because of this possibility of pseudo progression, can be seen a little bit later. So you always have to wait for maybe another scan for the next scan to absolutely make sure that the treatment is not working. Now, obviously, immunotherapy does not help all the patients. So it's important to kind of set that expectation in the beginning. how safe is immune checkpoint blocker compared to your traditional chemotherapies? And here we are looking at adverse events, or also called as side effects in a way. And if you compare overall these immunotherapy drugs to chemotherapy, the immunotherapy drugs are slightly better tolerated overall. For instance, in the studies comparing these two drugs, overall immunotherapy had a lower incidence of side effects, 67% versus 82%. Also, the severe side effects were also lower. You can see it's 11% versus 35%. Similarly, less number of patients had to discontinue treatment because of side effects with immunotherapy. And also the treatment-related deaths, which can happen sometimes, unfortunately, was also much lower with immunotherapy. This one, I think the biggest reason for us to monitor these patients closely is the possibility of development of special side effects from this immunotherapy, and we refer to them as immune-related adverse events or immune-related side effects. Now, these are very unique side effects, very, very different from your traditional chemotherapy side effects. These can be a spectrum of side effects, and these are, theoretically speaking, can affect any organ in the body. And you can see on the right side, the cartoon here, it can affect your liver, it can affect the lungs, the heart, the GI tract, blood, musculoskeletal system, etc. So any of these systems can be affected because, remember, it just uses our own immune system. And sometimes as this immune system is attacking the cancer cells, it can attack also the normal cells, leading to inflammation of that organ. So the reason someone has is because this inflammation from the immunotherapy, because of imbalance of tolerance to the drug and also drug-related immunity. So these are some of the basics of immune-related adverse events or immune-related side effects. Most of these start within the first 3 months of treatment. Sometimes they can occur later. They can be either mild or moderate, or sometimes severe. Moderate to severe immune-related side effects are typically managed with steroids, which typically calms down our immune system and decreases the inflammation. Sometimes you need to require steroids for a longer duration of time, and we'll go over that in a bit. Sometimes these side effects can wax and wane over time, particularly inflammation of the colon or inflammation of the liver. And as I mentioned, sometimes you can also have immune-related side effects that can occur even after you stop the immunotherapy. So what is the frequency of these side effects? These typically depend on, if the type of drugs that you're using, and also if they are used by themselves or in combination with other immunotherapies. Now, on the left side of the graph, you're seeing on the vertical axis percentage of patients, and on the horizontal axis, you're seeing each different side effect for each organ for 3 different drugs. So CTLA-4 inhibitor in blue, orange PD-1 inhibitor, and in green PD-L1 inhibitor. And on the right side is the same concept, but looking at severe side effects. So on the left side is mild side effects, on the right side is the severe side effects. And you can see in both the graphs that if someone gets a CTLA-4 inhibitor, they are the ones who typically have a higher chance of getting immune-related side effects, both mild and severe side effects. Also, the incidence of these side effects varies among different malignancies. For instance, if you get immunotherapy for melanoma, inflammation of the colon or colitis can be more common. Or in lung cancer patients, for instance, pneumonitis or inflammation of the lungs are more common. Are these side effects fatal? Yes, sometimes. But if you compare it to the incidence of chemotherapy, so in chemotherapies, the incidence of fatal side effects is about 1.4%. With immune checkpoint blocker immunotherapy, it is slightly lower than that. And it depends on, again, what drug you're using. It's slightly higher with CTLA-4 inhibitor at 1%, much lower with PD-1 or PD-L1 inhibitor. And with the combination is again a little bit higher at 1.2%. On the left side here, you see a graph which is showing what is the fatality for each of those side effects. For instance, just to take your attention to myocarditis, which is inflammation of the heart, has a highest mortality, meaning the highest chance of dying if you do get the side effect. Now, the chance of getting the side effect by itself is very low. It's actually less than 1%. But if someone gets it, then the chance of dying from the side effect is unfortunately close to 50%. Similarly, other side effects which can lead to death somewhere in the range of 10 to 15% could be pneumonitis and also myositis and hepatitis. So this graph is showing what is the kinetics, meaning how do these side effects develop over time in each patient, and if they resolve. So again, this graph with the vertical axis is percentage of patients, and on the horizontal axis is time in weeks. And you can see once someone starts immunotherapy, you can start noticing side effects. At about 5 to 6 weeks, you start noticing, typically you start with skin side effects like, your rashes and itching and things like that. It goes up over time. You can see at about 12 weeks or so, about 30% of the patients have some kind of skin toxicity or skin side effect. And then you can start seeing some GI side effects like colitis or diarrhea. Then you can have other side effects that appear slowly over time. Most of the times you can see that the curve kind of comes down, meaning that most of these immune-related side effects, fortunately, are reversible. Either by themselves, they go away on their own, or it may need steroids or other immunosuppressants, depending on the severity. The key for all the patients and even the providers or doctors is early recognition. Because if you don't recognize this, you can sometimes have severe complications, sometimes rarely even death. So it's very, very important to keep that in mind. This is basically the same data shown in the form of table. And you can see, so for each of the columns is what drug the patient was getting. And then each of the rows are different side effects. And you can see that with CTLA-4 inhibitor or someone who is getting the combination treatment, you can start seeing skin toxicity sometimes as early as 2 weeks. If you look at all of these side effects, the overall time of onset can be anywhere from 5 to 12 weeks. Now, this is basically a table showing real world data, meaning 1,000 patients who were getting immunotherapy, if they developed side effects and they came to the ER, what were those side effects that the patients had? So again, you're seeing a very similar, most of the patients or a proportion of patients got diarrhea, especially with ipilimumab or pembrolizumab or combination treatment at 18%. Similarly, other side effects are slightly lower. What are the different clinical features? How do patients present with different side effects? And I'll just quickly go over some of the important ones here. So dermatologics are skin toxicities. You can have a rash with or without pruritus. It can be in any body part, but typically starts in the trunk and can spread to other extremities. Diarrhea or colitis can, obviously you'll have diarrhea, sometimes even abdominal pain, fever, vomiting, and sometimes weight loss. Hepatic is nothing but liver toxicities. Mostly it is asymptomatic, meaning patients do not have any symptoms, but is detected on the blood test. Similarly, with pancreatic inflammation, it can be asymptomatic, but sometimes they can have actually severe abdominal pain, and nausea and vomiting. Endocrine toxicities are also pretty common, especially with thyroid. One can end up needing thyroid replacements for the rest of their life. Sometimes you can have severe inflammation of the pituitary gland, which is located near the base of the brain, and that can cause headaches or vision problems or fatigue, any of those side effects. Pneumonitis is inflammation of the lungs. You can have shortness of breath, cough, or fever. Kidneys can be affected. You'll have elevation of creatinine, meaning kidney numbers can be elevated. This can either be symptomatic or asymptomatic, meaning no symptoms, or sometimes they can have symptoms. You can have vision changes. Neurologic side effects can sometimes be very scary. Some patients have noticed like sudden onset weakness in the legs, sometimes confusion, not being able to walk or not being able to talk. That sometimes that can be very, very scary. Heart side effects, which is cardiovascular, you can have swelling of the legs, you can have shortness of breath. And lastly, musculoskeletal, you can have joint pains, joint swelling, muscle aches, muscle pain, etc. One question sometimes patients ask is, are there any risk factors for development of these side effects? Yes, there are certain risk factors. We always look at if someone has an autoimmune disease at baseline, and are they being treated for that? These patients, typically we sometimes even avoid immunotherapies in these patients. In patients who received CTLA-4 inhibitors such as ipilimumab after receiving a prior PD-L1, which can sometimes happen, usually have a higher risk of developing immune-related side effects. So we do have some general guidelines for management of these side effects, and it basically depends on how bad is it or how severe is it. If it is, and in our, we typically grade them, meaning how bad they are. It can go from grade 1 to grade 4. So obviously grade 1 is a milder form, whereas grade 4 is the more serious and life-threatening consequences. So the treatment typically depends on that. Most of the times for grade 3 and grade 4, and sometimes at grade 2, we have to obviously stop the immunotherapy. Sometimes patients might need hospitalization depending on the side effects, and we have to initiate steroids in these patients and to calm down the immune system, and we need to continue steroids for at least 1 month. When someone is getting a long duration of steroids, we typically have to continue steroids for about 4 to 6 weeks sometimes. We have to gradually taper it over time. You cannot just stop after 3 weeks or 2 weeks. You have to go down on the dose every, for instance, 10 milligrams every few days, and then gradually stop it. Obviously, steroids themselves can have some side effects. It will increase the blood glucose, especially in someone who has baseline diabetes. We need to keep that in mind. It has other side effects like gastritis. It can increase the acid secretion. That's why we sometimes put patients on acid suppressants. These patients are also at a risk of increased risk for opportunistic infections, especially fungal infections like PJP, and we start them on antibiotics for prevention. And also, long-term steroids can obviously reduce bone densities, so your bones can become weaker. So we do recommend doing calcium and vitamin D. Here, I want to mention some of the special side effects quickly here. So dermatitis, which is again skin. We typically ask patients to send their photos. Sometimes we need to consult dermatology. If it is mild, then typically we treat symptomatically, like with itching, you give antihistaminics or anti-allergics. For much more severe, some patients need topical steroids or even systemic steroids. And obviously we hold the immunotherapy treatment. Colitis or inflammation of the colon, enteritis is inflammation of the small intestine. Again, you can have watery diarrhea with increased frequency. You can have a milder form or a severe form, depending if it's a mild to moderate form. Obviously, again, we treat symptomatically, meaning we try to decrease the frequency of diarrhea. We do have to sometimes rule out other causes of diarrhea like infection. We typically hold the immunotherapy if it is grade 2, meaning someone who's had 3 or 4 episodes of diarrhea in 24 hours. For higher grade, which is grade 3 and grade 4, which grade 4 can be life-threatening, again, we have to start them on high-dose steroids, so much higher than your grade 2, and then we continue it for several weeks. Sometimes most of the patients do respond to steroids, but sometimes we might have to add another immunosuppressant like infliximab on top of steroids. These are some of the pictures showing the colitis, all the arrows indicating inflammation, the white color patches in the colon. Pneumonitis is also an important side effect that can be life-threatening. Overall, it's seen in less than 5% of patients, fortunately. Patients can experience worsening shortness of breath. Their oxygenation might be dropping or lower. And we obviously obtain chest X-ray and a CT scan if needed. And on CT, there are very typical changes with pneumonitis, and we'll be able to diagnose that. Again, we have to stop immunotherapy, give high-dose steroids, and then gradually taper over time. And these are some of the pictures. On the left side, you're seeing someone who had inflammation of the lungs, that is pneumonitis, from immunotherapy. And then this patient had to be hospitalized, had to get IV steroids initially, and then oral steroids for the next few weeks. And then you can see how the lung kind of clears over time. Lastly, I did wanted to mention briefly about diabetes. There is also a possibility of developing diabetes with immunotherapy. The chance of this is about less than 1%, so it is pretty rare, but I did have 2 patients of mine who developed diabetes, and they had to unfortunately go on lifelong insulin after they developed this side effect. Some patients also ask me if someone who's had a side effect from immunotherapy, can they get more immunotherapy in the future? The answer to that basically depends on the grade and the severity, meaning can you re-challenge these patients with further immunotherapy? So it basically depends. If it's grade 4, most of the times we do not recommend further immunotherapy. If it's grade 3, in some of them, again, we do not recommend. Most of the grade 1s and grade 2, we can in the future try more immunotherapy, but we have to be very careful because there's still about a 50% chance of developing the same side effect. Patients are also interested to know, okay, doc, well, I got the immunotherapy, I had side effects and had to discontinue. Will that affect my survival from the cancer? And the answer is no. And you can see in the same survival graph, patients who had immunotherapy side effect, survival was very similar to patients who did not have side effects. This graph is again survival curves, and what it's showing is data suggesting that maybe actually if someone develops immunotherapy side effect, they actually go on to do better than someone who do not get any side effects from immunotherapy. And that is maybe an indirect way suggesting that maybe their immune response is much more robust to both the tumor and your body. And that's why these are the patients who might end up doing better overall. This last graph is basically showing again the survival curves, but it is looking at patients who received steroids either at baseline or who required steroids early on in their treatment with immunotherapy, or someone who has not had any steroids. And mind you, the indication for steroids is not immune side effects, but from some other cancer-related issues, like sometimes we give steroids for someone who has a brain metastasis, or sometimes to treat pain. So what this graph is showing is that patients who did not receive steroids for any reason, actually did much better overall compared to someone who were on baseline steroids, which is the blue line, or someone who got steroids early on, which is less than 8 weeks, which is in orange, which basically suggests that, obviously steroids are killing the immune cells in a way because it's an immune suppressant. And that may be the reason why it is very, very important to try to not give steroids if they don't need them. So we have to be very careful, especially early on. Immunotherapy treatment is obviously can be helpful, but it's also challenging to deal with side effects. So we do require a very multidisciplinary approach to caring for patients who are receiving immunotherapy. So you have a number of specialties involved, could be involved in taking care of such patients. Considerations for providers like me, we always have to anticipate immunotherapy side effects and identify them very soon. Make sure the patient does not have any baseline autoimmune disorders. When someone is getting immunotherapy, it is okay to get killed vaccines or inactivated vaccines, but typically live vaccines should be avoided. Make sure patients is not on steroids and know the indication for steroids in this treatment. And also, patient and family caregiver education is very important because of, the side effects can sometimes be very severe. Counseling the patients and their caregivers, as I said, is a big part of this. We have to set evidence-based expectations for benefits, as I was saying, that not everyone will benefit from immunotherapy. Some patients come in and have very high expectations because of, some popular success stories in the social media. Jimmy Carter had metastatic melanoma and he got immunotherapy with pembrolizumab and had a very good benefit and survival. We do have to let patients know that because it uses the immune system, benefits can take longer to emerge compared to chemotherapy. And also patients who have a very large tumor burden, because it takes some time for the immunotherapy to act. Some of these patients might not be a good candidates for immunotherapy. We also have to emphasize on importance of monitoring symptoms and reporting them promptly to providers. What I tell my patients is that if you have any symptoms that doesn't go away or becomes progressive, please let us know as soon as possible. Sometimes I do recommend patients to carry, or most of the times I should say, I recommend patients to carry an immunotherapy wallet card at all times, so that, if something happens, some side effect, if you're by yourself, someone can notice that and may think about, possible immunotherapy related side effects. Also, educating on the management of the side effects is very important. Please keep in mind that if you have to discontinue immunotherapy because of side effects, it does not worsen survival. And also, if someone developed side effects and had to get steroids, for that reason, again, it does not worsen the response or survival. Here are some patient resources for immunotherapies. This is my conclusion slide. Immunotherapies are obviously very effective, but not everyone will benefit. It is important that patients are kept safe with education of the care team, patient, and caregiver about side effects. Early identification and treatment of the side effects is the key. Sometimes, despite developing side effects, some patients can be re-challenged with further immunotherapy. Thank you so much. Thanks for listening, and I can take any questions.
Thank you, Dr. Kulkarni, for that presentation. I learned a lot. I hope everyone else did as well. There are two questions that came in so far, so I'll read the first one that came in.
Yeah.
The question is, have you noticed any impact on tumor progression or regression after cancer patients receive various mRNA-based vaccination regimens? For example, on successful PT or PET scans.
Yeah.
In particular, have tumors shown enhanced positive treatment responses, and has any increase in positive response been proportional to calculated tumor doubling rate?
That's a good question. So there's no evidence to suggest that when someone get an mRNA vaccine, it somehow changes the immune system and its response to cancer immunotherapy. What we do know, however, is that actually immunotherapy has some sort of protective effect on severity of COVID in someone who's getting immunotherapy. So that is something that we know, that has been shown, and that's actually a part of my research too. And we've shown that in someone who's had immunotherapy and who get COVID, the chance of dying from the COVID is much lesser compared to someone who did not get immunotherapy. So that's something that we are seeing. The other thing to keep in mind is after someone gets immunotherapy, after someone gets vaccine, like your mRNA vaccine in the axilla or in the arm, their axillary lymph nodes can become bigger because the immune system is kind of recruited in that area. And we have to be very careful if someone who has a tumor in the axillary area that can get bigger, and you have to keep in mind that's actually a response to the vaccine and not the tumor getting bigger.
Thank you. A second question that came in is, somebody has asked, they can't find any information on life expectancy with patients who have had a complete response with Pembro or Keytruda, followed by a relapse. Do you know where I can find any literature or data? Since my relapse, I went back on treatment and had another great response.
Yeah.
We suspended treatment end of 2021 and will watch and wait.
Yeah, so I think I can see the question. It's Doug. I think, Doug, you are one of the very lucky ones, I would say, to being in this situation. The quick answer is there is no data. Because all the way the studies were done, especially with lung cancer or most of the other cancers with immunotherapy, they were treated for a maximum of 2 years. And after that, what to do with patients who especially had, complete response. From some of the studies data that we have, it suggests that, in someone who had a complete response at the end of the 2 years, we might, it makes sense to consider stopping it because we see that about 50% of the patients continue to have a complete response despite stopping the immunotherapy, whereas the remaining 30 to 40% developed some kind of progression. But despite that, again, if you reintroduce immunotherapy in these patients, about 60 to 70% of them will again have a response, which is, I think, what happened in your case. So I think we still have to wait and watch and see for longer follow-up data and longer survival data to answer that question.
Cool. Thank you. And then the last question that came in, and we just have a couple minutes left, is if therapy is needing to be stopped, is the patient offered other treatment, or is the choice made to wait for worsening symptoms to go to something else?
Yeah. So most of the times we have to switch, if we have to switch therapy for whatever reason, then most likely we have to offer a different type of treatment. Again, if we had to stop therapy because of side effects from the immunotherapy, we might have to wait for a little bit longer so that they recover from all the side effects before starting the next treatment. And the next treatment will obviously depend on what type of cancer is it.
All right. Thank you so much, Dr. Kulkarni, and thank you for all the attendees for all the thoughtful questions and the presentation. With that, we'll conclude the session. Thanks
for having me.